Honored to have Dr. Avtar Singh, the famous orthopedic surgeon from Amritsar, who owns Amandeep Hospital in Amritsar.
All right.
He has got more than 35 years of orthopedic practice in Punjab, and it'll be great to hear from him his challenges and treatment gaps in treating osteoarthritis and osteochondral lesion. We also have Professor Leif, who is the founder and board member of episurf Medical AB's Stockholm. Over to both of you for your exchange on the new patellofemoral system.
Yeah, so very interesting. What are you doing? What is your opinion about what Mohan mentioned, the gap, the gap problem?
You see, I'm basically a general orthopedic surgeon, then drifted into arthroplasty. And on the way, I was doing some arthroscopies as well.
Okay.
And then there are many patients actually in the practice whom you want to put in some filler, but that is not there actually.
Okay.
And today I was happy to know when he was escorting me to this room that it's about that filler which is available.
Yeah.
So,
okay, great. So let me show you. We at Episurf we have been doing filler of cartilage lesions for 10 years now. And the lesions that we have addressed are the ones on the femur, in the knee, also in the talus, and we have an implant for the toe, big toe coming. Okay. So what we did in the femur, and we've been doing for 20 years, or for 10 years, is to make patient-specific guides that fit onto the knee, the part of the knee that is damaged. And then we have produced an implant, and I can show you this. So this is an implant for the trochlea. It's what we call a twin implant. It's a two. We also have a solo, which is just a round thing like that. Right. Our implants are made of chrome cobalt. They are patient specific.
Okay.
So they fit that particular part of that particular knee. They are coated with first titanium and then hydroxyapatite.
Right.
So they grow into the bone.
So that means that you will need a CT scan or MRI or both before you can order the implant, right?
Precisely.
Especially the cutting zig. That will be based upon the lesion which you see on the CT or the MRI, right?
Precisely. So the first thing we do is to get an MRI. In the knee, we use MRI. We get that and we reconstruct the knee in the computer.
Okay.
And we produce a damage marking report. That looks like this. So this is this particular knee and how the lesion looks. The pink is superficial, the red is a full thickness lesion. And then together with the damage marking report, we add the relevant MRI slices.
Do you need some special kind of MRIs or they are just routine MRIs which we have in the country?
Unfortunately, we are working on the standard MRIs, but for the time being we need special sequences.
Okay.
That it's not, you don't have to rebuild your MRI machines, but you have to fill with the settings a bit to produce, let's call it a macro of our sequences, and then they can.
So they will need a new software for the MRI?
No.
So it's the
it's
same
just
standard MRI with some
yeah.
fine tuning. You mean to say?
Yes, precisely. So no rebuilding, no new software. It's a simple thing. And that we send to you the damage marking report, and you have a look at it and you say, okay, this looks nice. Or you can say that, nah, I don't want to, I think we should move this a bit to this or that way. And then we communicate over a platform on the net.
Right.
And then you say yes, so fine, and then it takes us another 4 weeks to actually produce.
To make the implant.
Yeah, to make the implant.
Right.
And we send it to you in a kit, sterile, with all the instruments that you need, basically this stuff that I'll show you.
And it's a non-cemented stuff which you put in?
It's the trochlea can go in non-cemented, but we need to cement the patella button.
Okay.
Patella button.
Yeah, that.
Because that's a new thing with this. Previously, we've been doing the cartilage, we've been resurfacing the cartilage, but now we are going into osteoarthritis.
Right.
So where both the femur and the patella are worn. And then we need the patella button, and the patella button is also patient specific to fit the particular implant that fits the particular knee.
Okay.
So it's all patient
So
specific.
both are patient specific.
Yes,
Right.
yeah, yes. But this is cemented.
Can you see? Okay.
Yeah, absolutely.
And this
And
is
that is-
made of what?
It's high molecular weight, medical grade polyethylene,
Okay.
cross-linked and doped with vitamin E.
So it's
Straight
vitamin E poly basically.
Yeah,
Right.
yeah, state of the art, best possible we could find. So, what we do here is to, we put this on, we drill it using pins, pop, 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 and this will find, and I think you can feel it yourself. You can feel, that's how it goes. Yeah, you can
Yeah,
see how
it
it
fits in.
snips into one place.
And you then drill it with this.
Yeah, or rather we drill it with this actually. So what you do at that stage, when you have it like this, we put this one in, and we drill
Pin this.
using, we pin that in, and we drill this to get one central hole.
Right.
So that's a drill socket. Then we put the adjustment socket in, and has these markers so you can incrementally twist this, and by doing so you lower the drill depth by 0.2 millimeters. So now when you have a cartilage lesion that we've used to have, we want to put the implant in recessed 0.5 millimeter below the cartilage, the surrounding cartilage.
Right.
In osteoarthritis, we don't have any, or not always at least, surrounding cartilage. So then you want to put it in perhaps flush with the bony surface.
Right. Right.
So you drill that, and then once you think you're happy, we have these. We have a dummy, which is an exact replica of the implant,
Right.
and you put that in, and of course you drill it like this, so you get a twin, and then you check with this that you are okay, where you want to be, depending a bit on how the surface looks, and then when you're happy, you put this up, you implant it.
And what's the longest follow-up you have with this?
With the resurfacing, our first patient was operated 11 years ago.
Okay.
And he is still walking in the Italian Alps.
And what about the progression of the disease? If the disease is progressive, and then you have to do a total knee or a uni knee, then what's your take on that?
It's an interesting question. I believe that we will soon be able to say that we actually stop the osteoarthritic process.
Okay. You mean to say that process starts in the patellofemoral and then it
No,
spreads?
well, no. That depends. I think it probably starts more often.
here,
It starts
actually,
here, And in at least in Sweden, we have the ONE is a varus knee, so it breaks down the medial
like
compartment.
everywhere in the world.
Yes,
It's
yeah.
basically varus knee actually.
Yes. And so, but again, our first patient is 11 years down. I believe that the OA process starts, you may not agree with this, but I think it starts with a trauma, early age.
Maybe,
Oftentimes.
may not be actually.
Yeah. No, not all the time, I agree. Because
My question is, like the way you are putting an implant here, why not make a similar implant for the medial?
but we
femur?
do. We
Yeah.
do. Oh yes, we do.
And that's also custom made?
Yeah. Yeah,
Okay.
sure. Yeah, sure. And we have the same. We have. I mean, We have this one that goes.
Okay.
That goes.
So you can do this also and this also.
Absolutely.
Okay.
Absolutely. But we don't for the tibia we don't have an opposing polyethylene component for the tibia.
Okay.
So if you have a hole in the femur here,
then you can
and that's
just-
what we've been doing for 10 years.
Yeah.
And these patients, we have a very low revision rate. We've actually reported on that and we've published on that.
So you put a similar button here.
Yes.
Okay.
Yeah.
And
Patient specific.
this moves on the cartilage.
Yes.
Okay.
Yeah. And cartilage is okay with that.
Okay.
Seems to be.
And why not make this with ceramic?
Yes, we actually we started with ceramics, but it's hard to make a patient-specific ceramic component.
Okay.
Because you can't machine ceramic. You have to.
You need to talk to the ceramic company actually.
I know, and we did. we did. We have talked to them many years ago.
There is
Yeah.
another material actually which is coming up, which is PEEK.
Yeah. PEEK. I think this is made of PEEK,
Yeah. Similar.
and it's not hard enough. It's
Okay,
not.
it's not
It's
hard.
not wear
Right. Just for the
resistant. Yeah. Right.
Good.
So we put this in, and basically that's how we do it. And for the resurfacing, when you have a focal lesion in the cartilage, we've done that we are approaching 2,000 implants now over 10 years.
Right.
And what we've shown is that the coating, I mean, we knew that bone likes hydroxyapatite, so it attaches to bone, but also cartilage attaches to the hydroxyapatite.
Okay.
And that means that we are sealing the hole in the cartilage.
Right.
So joint fluid can't be squeezed down into the bone, causing osteolysis and implant
So
loosening.
now it doesn't squeeze into the.
No, no.
Okay. The cartilage seals that.
Yes, we don't have
Okay.
a single case of implant loosening. Not a single
How many
case.
total you have done? You said?
About 2,000.
And the survivorship is like, how many you have revised actually?
We have revised in the order of 30.
That's
nothing. It's really
that's nothing.
We have a publication, and you will get. We've published on that.
Good.
So that's basically what we're. So the new thing for us is the bipolar implant for osteoarthritis, with a button that goes. That goes into. We have only put in very few of these. We have no
The
follow-up.
bipolar.
The bipolar.
How
We
it
have-
looks like?
Well, it looks like here you have the bipolar, and here you have one case. Here you see, here it looks like this.
Okay.
And here is an actual implant that was put in the United States.
Right. And this is the patella?
Yeah, this is a patella and that's a trochlear case.
Okay. It works like that.
Yes, and then you
Good.
flip the patella back.
Interesting actually.
Good questions, good questions.
I could learn new things and hopefully
Yeah.
they'll become more popular.
Yes, we hope so. We do think we have a place.
Yeah,
We
it
have,
has a
there
place.
is a gap that we can fill. And,
With select surgeons you can do it. It won't be like TKRs which are happening everywhere.
yeah.
It will be like a very niche market actually.
I think so too. Yes, I think so too. Although I think that very many patients that end up needing a total knee,
Yeah.
they would have had the little lesion 20 years earlier.
Maybe.
And so we had, and
So now we are entering that bracket. If we get anything like that,
you should have an MRI done.
yes, and then I send my MRI to you.
Yes,
And
yes.
then you plan it for us, and then
And you know what we do is that we look at ordinary standard MRIs.
Okay.
And we make a first assessment, and then we say, yeah, this is a possible patient.
right,
And then we require, a special MRI.
elaborate MRIs.
As of yet, we do that.
Right.
But we can handle ordinary MRIs
Right.
actually at no cost.
Right.
At no cost.